I want the patient to be arranged in a way where they're getting the least amount of sensory input as possible. So the wrist is hanging off. All right, so we're looking at central nervous system. We're starting distal to proximal. And when I touch her, I'm just going to touch her with this hand and as little as possible. Okay? I want to give her as little input as possible. And I'm going to say to you, hi, Adriana. So today we're gonna check out how you feel moving in your hand. Okay? Don't talk about proprioception. Don't talk about kinesthesia. We're going to check out how you can feel your hand moving. Okay? We're going to make believe this is her uninvolved, okay, right now. Of course she knows. So, and I want you to notice where I'm holding her finger on both sides really lightly. So look at this. Everybody see this? Okay, this is her less affected side. So, Adriana, I'm going to move your thumb up or down. You can look at this, okay? And then you're going to tell me, is this up or down? Okay. So, is this up or down? Up. Is this up or down? Down. Okay. And then I'm going to ask you to close your eyes, and then you're going to tell me, is this up or down? Up. Is this up or down? Down. What do you think is harder to feel, more range or less range?
Less.
So you want to move through sort of mid-range initially. If she's not feeling it, don't say, oh, is this up, right? Because what are you doing when you're doing that? You're stretching more of the joint capsule, right? Don't do that. Right. So stay in mid-range. Sometimes, and you can decide how you want to do this, but be consistent with yourself. Some people just bring the thumb or the finger or whatever part back to midline, okay? And sometimes people do a little jiggle in the middle, and then don't do anything. You can let go and just bring it back to neutral, and then you can do, is this up or down? You've got to sometimes give the patient a moment to feel it, but then how long do you wait? Guess what? There's no standardization for that. At least 3 trials, but I would say 3 to 5 trials for all sensory testing. So you can say patient identified 3 out of 5 trials for proprioception, right? Okay. So that's how you can record it. It could be 5 out of 5, or you could just say intact. If they're getting 5 out of 5 on all of them, just say intact. What you want to do as you go through all the fingers is you don't want to do the same direction every time. So don't do up, up, down, up, and then go to the next finger and do up, up, down, up. Mix it up, right? You don't want them to start to predict and have it be a learning effect. Go through all the fingers. Let's say I do this and she's impaired at most of her fingers. Let's say she's, 2 out of 5 or 3 out of 5 out of most of her fingers. What do I do next? CNS. Go to her wrist. Keep going, because what am I looking for? The first intact segment. So for her wrist, again, I'm going to hold her gently around her carpals, and I'm going to demonstrate first. This is up, this is down. Okay, then close your eyes.
Up, up, down, up.
So if this is intact, I'm going to say, fabulous. If it's not, I'm going to go to the elbow. Okay? This is up, this is down. Go through all the fingers, lightly touching on the outside. And feel the difference if I held you like this. Yeah. Right? Or if I took you through end range.
Yeah.
Right? It's a lot more input. Okay, and that's basically what you do. I would do the less affected side first, then the affected side, because then you know that they know the test, right? Enough of a distribution, enough points. So I'm not just doing 1 per finger, right? If I'm doing it in the dermatome, I would at least get, I think dermatome is like 3 to 5. And you have to get different points along there.